Good afternoon and welcome to this basic lecture on clinical aspect of MRI. I will try to teach you how to interpret a report, what are MRI sequences, and this is a lecture for non-radiologists. And I will focus on how the developing brain looks like normally and in case of diseases. Now, a child brain is very interesting because when you have a problem, when you have a disease, a pathology, they can different pathologies can look very similar. Um, because the brain really have few ways to react to an insult. So in the developing brain, different things can look very similar. And this is of course a joke, but just to show you how different things can look similar. But this is also very rapidly evolving brain that change very fast. So the same things in the developing brain on MRI can look completely different over time. Now, learning objective, I will show you the basic principle of magnetic resonance imaging, and I will show you the anatomy and pathology of the developing brain using MRI. The second part of the lecture, I can do another time. There will be another video on that and will be about functional MRI techniques. So let's start. How we look into the brain. We look into the brain using an MRI system. This is how it looked like. It looked very similar to CT. And this is the definition from Wikipedia. Magnetic resonance imaging is a medical imaging technique that used to form picture of anatomy and physiological process of the body. And importantly, MRI scanners use strong magnetic field. So this is the first important difference from CT. CT uses basically um, um, radiations, which are of course more dangerous, especially for children. Here we use magnetic fields. And in order to image the brain, we use several sequences, and every single sequence shows different information. And we can have anatomical information as well as functional information. Now, what are the important sequences? When you read a report, you will have different things that are called T1, T2, gradient, diffusion, and so on. So I will show you what are the important sequences. First of all, T1 and T2. These are the most basic, most important anatomical sequence. And the thing that you need to remember is that everything that is water or full of water looks bright in T2. So if you have a tumor, especially a low-grade tumor, which is edematous by its nature, it will be actually bright in T2. If you have an MS plaque, will be bright in T2. If you have the normal CSF liquor, so the normal liquor into the brain, it will look bright because it's very similar to water. While the water and things that are full of water will be dark in T1. So bright T2, dark T1 is the appearance of the water. And then we have this specific sequence that is called FLAIR that was actually invented for the patients with multiple sclerosis. Is actually very useful to see the pathological process close to the ventricles, so close to the areas of the brain that are full of water, because basically the FLAIR is a T2 sequence where the signal of the pure water is artificially suppressed. So what we are left with is pathological processes. And I will show you some example. And then we have gradient sequence that are sequences also T2 weighted, we call. So it's part of the family of the T2, but they are very sensitive to blood and calcium. And finally, we have the diffusion, which is sensitive to acute damage and other things. So these are the main sequences that you need to be familiar with. And this is how actually an adult looking like brain, so a brain that is completely myelinated, looked like. And you can see here we have axial T2 of the brain. Here in the center, I'm pointing at the ventricle that are very bright because this is a T2. And then you have the white matter that is dark in T2 and the gray matter that is a bit brighter than the white matter. So it has this intermediate signal between the CSF liquor and the white matter. So we have liquor, white matter, gray matter. And also you can see the spaces around the brain also full of fluid. In the T1 here, this is just another cut, it's a coronal, and we can do different sequences in different orientation. This is why MRI takes so long. In this coronal, you can see the opposite colors, let's say, so the opposite intensity in comparison to the T2. You have the dark signal in the liquor, the bright signal in the white matter, and a bit darker than the white matter, but brighter than the signal is the gray matter. So again, from the external part of the brain to the internal part of the brain, we have gray matter, white matter, and CSF or liquor. This sequence is a coronal like the T1, but it's actually a flare. You can see that the appearance of the white matter and the gray matter are extremely similar to the T2, but we suppressed artificially the signal of the liquor. So basically, the flare is like a T2, where we suppressed artificially the signal of the liquid. And this is not very beautiful sequence to look at. It's a bit more blurred, but this is a gradient, which will be very powerful tool. I will show you some example looking at the blood and calcium. So what we learn is that the fluid, the water is bright in T2 and dark in T1, and white matter, that's very important, is dark in T2 and bright in T1. There is a reason why it's like that. Let's see this brain. This is a brain of a child which is 2 days old. So this is a son of a control of a of someone who was another control. So we did 2 scans of normal newborn and his father. Now look at the difference. This is a T2 in the axial. This is a T1 in axial. Look at the complete differences in the appearance of the white matter. This is very similar to water. This is very, very dark. So the signal here is very similar to the CSF. So why is that? And same in the T1. This is the fluid here. Look at the white matter. It's very similar in signal to the water. Why? Because this is an unmyelinated brain, and an unmyelinated brain is a brain where the white matter is full of water instead of myelin. Over time, the myelin accumulate and we have this change. And this is why when we look at the scan, for instance, in patient with epilepsy, we need to take in account the myelination that can give us some physiological blurring that can simulate focal cortical dysplasia. So remember that this is a brain that changes very fast. And what is myelination? Well, this is the axon. So this is white matter is already present. And then over time, we have accumulation of myelin that basically is done by lipids and proteins that accumulate. Now, over time, we have then in the brain, in the white matter, an increase of lipids and reduction of water. Now, why this is important for us? What changes in the signal is actually that there is, over time, reduction of the water, so the brightness of the white matter reduces, and accumulation of lipids. Now, in T2, what we see, we see more is the reduction of the white matter signal. In T1, what we see, so we are visualizing 2 different phenomena, we focus more on the accumulation of lipids. And this is why we have these changes. So over time, we have that in T2, the white matter becomes darker, myelination. The same is in T1. Just the white matter become brighter. So we see the myelination in 2 different sequences. But because we are visualizing 2 different phenomena, because I told you at the beginning that different sequences are actually very powerful because they see different part, they have different specificity. In this case, T2 we visualize the reduction of the water, T1 we visualize the increase of lipids in the white matter. So again, when completely myelinated brain, we have liquor, very bright in T2, very dark in T1, white matter, dark in T2, bright in T1, and this intermediate signal of the gray matter. We know that there is a myelination pattern, so we know that myelination starts from the center to the periphery, and then posterior-anteriorly, and then caudocranially. So very important to consider not only the timing of myelination, but also the direction of myelination. But remember, because in T1 and T2 we visualize two different phenomena, the timing of complete myelination is different in T1 and in T2. And this is actually, this I took from Wikipedia, shows you actually the different timing in the different sequences. This is a sagittal T1 of the brain. This central part here, for those of you that are not familiar with the anatomy of the brain, this central part in sagittal is the corpus callosum, this big bundle of white matter connecting the two hemispheres. Look what happened over time. The corpus callosum becomes thickened and brighter in T1. Why? Because the child is myelinating. If there is something wrong, so the child at that point when it's born has a HIE, what we have is a dysmorphic and small corpus callosum. So the myelination happens, so the corpus callosum is bright, but actually it's very small, particularly posterior. So this is a scarring in the corpus callosum due to the fact that before the process of myelination, there was a hypoxic ischemic injury. Now look at these two patients, one on the right, axial and coronal T2, one on the left, axial and coronal T2. Now, what is the difference between these patients? Actually, if you look at the scan, there is not much difference, and both of these patients are non-myelinated. However, what is important is the age of the patient. The myelination should be completed by 2 years old in T2 weighted signal, but in this case, this patient is 4 weeks old, so it's fine, almost completely unmyelinated brain. 2 years old, this other patient did not have any myelination, and this is a hypomyelinating pattern. So not only what we see is important, but also the timing. So remember that the MRI is a very, very powerful tool, and this is an hypomyelination pattern, and the name of this disease is called Polyzeus-Metzbacher. So this is very important. Another important thing is that I told you before, different sequences visualize different phenomena. And what we have is that in this case, we have a T2 almost unmyelinated, but so bright signal of the white matter in T2. Can you see it? But look at the T1. The T1 is bright as well. So we have a discrepancy because we expect that as more T1 signal become darker, the T2 signal in the myelinating brain should become, brighter in T1 should become darker in T2. Okay, so normally these should be exactly the opposite. But in this case, we have bright. And this is typical of what we call hypomyelination on MRI. Very, very important. And the hypomyelination pattern has been defined as a discrepancy between the signal in T1 that looks myelinated and the signal in T2 that looks unmyelinated. This is a mutation, HSBC is a tube B4A mutation, but this is not very important, just to show you the concept of radiological appearance of hypomyelination. Now, I want to tell you something about, so I told you about T2, T1, and how they visualize the normal and abnormal process in myelination. Now, diffusion sequence visualizes the water, the movement of the water between the cells. So these are cells, yellow, and then this is the Brownian movement of the water molecule. Now, when this movement can be restricted, if you have the acute phase of an ischemia, you will have that the cells will swollen, and before to die, there will be this moment where they will be swollen before to literally explode. So the water between the cell cannot move so freely, and this is what we call diffusion restriction. And diffusion restriction, this bright signal here, and this is called ADC map, apparent diffusion coefficient, and it's basically a map that is the mirror in terms of signal of the DWI. So you can see whatever is bright in DWI is dark in ADC. This is the same sequence. It's just to show you why sometimes you read in a report DWI, sometimes ADC. This is just to check that this is real. So is some sort of technical way to check that the restriction is real, but this area is the area of an acute infarction, and DWI, diffusion weighted sequence, is the only sequence that can allow us to diagnose an acute ischemia in the first 5 days. It's very difficult to pick up in CT and a bit more difficult in the other sequences. There are, however, other situations where the diffusion between the cells is restricted. For instance, maybe not big cells, but a lot of small cells. And this is typical of children with embryonal tumor. Different from adult tumor, the cells are so many and so packed that they create a restriction. Look that this tumor is brighter, this is a medulloblastoma, brighter than the cortex that is already packed. Okay, so remember, diffusion restriction very useful for acute infarction and for the embryonal tumor, so useful for the differential diagnosis. There is a third situation where the diffusion restriction is very useful. Pathological situation is pus. When we have an abscess, the central part of the abscess is full of debris and there is no water, and basically there is a striking diffusion restriction. Again, DWI, diffusion weighted image, is bright, and ADC is dark, exactly mirroring the diffusion weighted image. Now, when the child is just born, we have that basically the child has unmyelinated brain, but there are some part of the brain, the central part of the brain, that should be myelinated, in particularly the posterior limb of the internal capsule, already myelinated at birth, and the posterior fossa structure. But because these are myelinated, these are extremely active areas, and this is why these areas are susceptible to acute damage if something goes wrong. This is a 13-day-old child that started to be very sick. We don't see the myelination in T2. This is a T2 sequence. Look at the bright signal of the liquor, but the central part here, the plic, should be dark because should be myelinated. We don't see that. Look if we do diffusion. This is a myelination map. Everything that is supposed to be myelinated, so is metabolically very active, is actually damaged. So there is a diffusion restriction, so there is an acute edema into these areas. And this is why, because the child has a neurometabolic problem that is called Maple-Syrup-Urine disease. So DWI is very helpful in pathological situation when there is an acute damage. Remember that. Companion case, again, the central area of the brain shows diffusion restriction. This is a T1. Why? Because the liquor is dark here and there. There is no myelination. So the white matter is again similar to the darkness of the liquor. So it's full of water, so it's not myelinated, but the central part is myelinated. You see a bit of brightness here. Despite that, there is also an acute infarction. What's the difference with the previous? Well, there are some difference. The signal is a bit more extensive, involve the basal ganglia, but the important thing is that this is 1 day old. So in this case, there was no symptom-free interval. The other child gets sick when it was 13 days old. So you can see how important are 2 weeks at this age, and actually, why they are so important in the differential diagnosis, because this is ischemia that happened at birth. The other one was actually a neurometabolic problem due to a defect of did not allow the child to metabolize some substances that became toxic. So what happened was that actually these substances, these catabolites, needed few days, a couple of weeks to accumulate and give the problems and give the symptoms. So this is why a symptoms interval is very, very important. So this is an HI, so hypoxic ischemic encephalopathy at term. Again, diffusion restriction critical for the acute damage. Look at this other child, another pathological appeal. So I will show you some very interesting pictures just to show you how pathological processes in a young child look like. This is a 10-year-old child with normal pregnancy, delivery, and development, T2, because the fluid is bright. And then there is darkness of the white matter, completely myelinated, and this intermediate signal of the gray matter. So gray matter, white matter, fluid. Look at this. This is a 10-year-old child, same age, with extreme prematurity, cerebral palsy. Where is the white matter? There is no white matter, a bit here, a bit there, but a loss of white matter with enlargement of the ventricles that basically compensates for the lack of white matter. And this is white matter injury of prematurity. Same here, you can see X-prem, so 17 month, you can see this abnormal signal. It's not as striking as the one before, but look at this abnormal signal, okay? And also a bit of squaring of the ventricle, reduction of the posterior aspect of the corpus callosum, and also dark signal, meaning water, meaning gliosis, meaning damage in T1. So you have T1 sagittal, T1 coronal, and here far left, T2 axial. This damage is again white matter injury or prematurity, just less striking than the one before. And you can see here how the abnormal signal is visible in the white matter that is still a bit normal around these areas of gliosis. And the differences for in comparison to a normal corpus callosum are quite striking. And here we can have a bit of signal, but these are just perivascular spaces, not as striking as that. So again, T2, T1 sagittal, T1 coronal, okay? So this is again periventricular leukomalacia in the context of white matter injury or prematurity. Finally, I would like to show you the injury of the developing preterm brain that can also be intraventricular hemorrhage. These are the appearances of the pathological spaceman, because of course, unfortunately the child died. But look, this is a gradient. Everything that is very dark in the gradient sequence that I told you is the most important sequence for the detection of blood and also calcium. This is blood. It's dark, it's in the ventricle, and it's very bright in T1. We have a T1 sagittal, T1 axial, and a gradient axial showing this blood here. So remember, diffusion weighted for the acute damage, gradient for the blood and calcium. Hypoxic ischemic injury, this is a T1, this is a T2. Look, the central part of the deep brain is dark in T2, bright in T1, is myelinated. So most of the brain is not myelinated. Now you can recognize when the brain is not myelinated, but the central part is actually myelinated. This is a term neonate. And this is the posterior limb of the internal capsule, and this is the ventroposterolateral thalamus. If you have a profound HIE, the myelination, this bright signal, goes away. But again, the most powerful sequences to pick it up will be the diffusion. And speaking of, this is from Charles Rebaud, there are two different patterns of damage. This is a diffusion restriction. This is a T2, the rest are diffusion in two different patients. This patient here was a preterm baby, and you can see that the pattern is more periventricular, while the central pattern of diffusion restriction here, here, and there is more of a term baby. So preterm and term baby babies have different area of susceptibility depending on the most active areas. And in particular, remember the term baby is myelinates in the central part of the brain. The preterm develop periventricular leukomalacia because the periventricular areas are the most sensitive one. So remember this concept of selective susceptibility, very, very important when it comes to preterm versus term babies. Another interesting thing is this is a CT, it's not an MR, but look, this is a brain with an enlargement of the pericerebral spaces. This is 5 months old, 19 months old, the brain catched up. So this is not pathological. This is called benign enlargement of the subarachnoid spaces in infant. Now, why this is very, very important? I show you the CT, but it's very important because this is completely normal, just due to the fact that there is a discrepancy in the growth speed of the brain in comparison to the skull. Previously known as external hydrocephalus, benign communicating hydrocephalus, and so on and so on, we need to call BES, benign enlargement of the subarachnoid space of infant. This is a lecture on MRI. I want to show you the MRI aspect of this. You can see there are these small vessels here. These are bridging veins, typically part of the subarachnoid space. If there are no bridging veins, these are not subarachnoid space. Let's come back one moment to the CT. Look at this other child. This child is very sick. Here, there is same size of the spaces surrounding the cerebrum, but look, the density in the CT is a bit different. There is an extra space here. These are actually subarachnoid space. This is an extra space. It's subdural. So let's look at the power of the MRI in picking up subtle differences. In this case, there are no vessels here. So the subarachnoid space is here. You can see some vessels. This is subdural space. When you see enlarged subdural space in a young child, think of abusive head trauma. In this case, if you look at the CT a bit cranially, there was blood and there was this area of darkness here that is ischemia. So I will show the combination. I showed you the combination between CT and MR because in case of non-accidental injury, we normally have both. Just to show you that with MRI, we can see the anatomy and the pathology of the brain very, very well. Just we need to look at small differences between the pattern on images. Again, this is a diffusion weighted image, and these are the ADC map. Can you see this area of brightness here? These are acute damage. And can you see these areas of darkness here? Again, acute damage. We have sometimes neonate with seizure presenting with this query neonatal stroke or query MCA infarction. What is that? Well, we can see also in T2, believe me, this is a T2 and T1. So T2, T2, T1, T1. These areas slightly bright in T1, slightly dark in T2. These are very small area of ischemia along this structure that are called deep medullary vein they go from the cortex to the ventricle. So this is actually also important in these cases to look at the gradient. Again, the gradient sequence is the sequence sensitive to blood. Look, we see that these veins are engorged and full of blood with some hemorrhagic periventricular changes as well in this patient. So what are that? These are called punctate white matter lesion of the infant associated with deep medullary vein thrombosis, very, very frequent cause of seizure in the neonate. You need to be aware of this pattern and you need to be aware of this nomenclature when you see it. And there are these two papers that show the same pattern in both the children. So in several children, and they also show that these are small areas of ischemia. So punctate white matter lesions are foci of ischemia along the course of deep medullary vein, hyperintense in T1, hyperintense in T2. Diffusion weighted can be positive or negative depending if the lesion is acute. Susceptibility or gradient in gradient sequences can be positive or negative depending if there is blood. Okay? So this is the end of the lecture. I have a part 2 with functional images that I can do at any time and send it to you. So thank you very much, and have a nice day.